All right, so while they're loading my slides on, I would like to just say that, there are lots of people here. One of the things about this summit that's really great is because of the people who are coming along with this. So, I mean, this was started, I still remember I was telling Professor Zidman earlier on in the evening. Still remember the time that was in 2015 when we had this first event. And that was just down here at the Longwood Medical. And it was a few collection of people who came up and really wanted to, bridge this divide. Like Lisa said, the fact that you are born in Africa or in another lower middle income country and you have cancer, but you don't have any access. And one of the very compelling things that Professor Zinman mentioned was, talking about his own story in Nigeria, and my brother was actually there, said he was the one who was the most eloquent, who was able to communicate the problem in a language that the layperson could understand. He's coming from a religious background, so he doesn't understand those big terms, scientific words. And I really learned from that, which was that, sometimes we cancer specialists, we talk to each other a lot, right? And it can get things done. But we need to talk beyond ourselves. And that's something that Mel has really brought onto this whole platform as well, being able to engage the government. We have a lot of government leaders, when I acknowledge all of you here, a lot of really luminaries who normally would not be here because we're at the cancer conference, right? But, now we are engaging that very broad spectrum of people who can actually shape policy. Let me give you an example. So PEPFAR actually started, it's one of the biggest global health program ever, I would say, right, by the United States. And it saved millions of lives in Africa. But that was actually because the government of the United States, decided to put this policy in place. Okay? That saved a lot of lives from HIV/AIDS. And now, as people live longer, people are surviving from HIV/AIDS, guess what's happening? Cancer, non-communicable diseases are becoming the frontier. And as Dow Wilson in his talk showed, cancer is becoming more than all these communicable diseases. And so we need to kind of shape the policy now and move it towards non-communicable diseases like cancer. And all of you here are really needed in that response. So that's something that I really just want to mention because talking to other people is very important. One last group that I would like to recognize here is that we have the sports and athletes who are going to be having a very nice session tomorrow. And they're dealing with things like mental health, right? Cancer patients have to deal with mental health issues. You may have heard from people who talked about earlier on today, like Professor Nyong'o, Governor Nyong'o mentioned about what the diagnosis for him meant. It's a difficult thing to deal with, but then when you have family, like his beautiful wife here, who can really support you through that journey, the mental health challenge can be a little less, right? But that's not just in cancer. There are most of us here, there are many people here who deal with mental health issues. Right? And so we're very proud that the athletes, the sports community can also partner with the Global Health Catalyst to talk about mental health issues, which also affect them, by the way, like the NFL players with concussions and stuff like that. And so they're coming up with really innovative solutions. And that's what Harvard is really about, right? You have really cutting edge innovations that can have a really high impact that they want to support. And so we are very proud. We want to recognize the sports community. Can you please stand so we recognize you? We have Coach Hugh Jackson, who was the coach of the Cleveland Browns, and we're going to have Calvin Johnson and a number of other luminaries here tomorrow in the field. And please sit down. We really appreciate your being here. That's really important. We look forward to collaborating with you. All right, so I'm going to quickly talk about curative cancer treatment for $300, less than $300. Okay, and it's kind of part of the vision for the Global Health Catalyst. The fact that all cancer patients can afford treatment. And Mr. Win-Win, my brother Ahmed over there always tells you that, right? Like, that's the first thing. Scientific evidence for ensuring more affordable access to cancer care. And the truth is that you can come up with really good cures, but if people don't have access to it, it doesn't really mean anything. Okay, and so I'm going to talk a little bit about how we can address some of these cost issues. I was invited to the American Cancer Society Cancer Research Conference earlier in April, and giving a talk about immunotherapy that won a Nobel Prize last year, combining that with radiation. And after that, one of the people who came to me said, they really liked my talk because, is Upender here? Yeah, he's right behind there. So he said he really liked my talk partly because that was the one talk that talked about immunotherapy, using that combination for the rest of the world. Because most people cannot afford that treatment in the developing countries. It's something that, the cost is so high that, even here in the United States, when you're diagnosed, you have to get that, you have to deal with financial issues. You have to think about that, right? So I want to talk a little bit, and it's going to be brief so that, we can get our awards winning ceremony going. All right, so let me show you this picture here to the left. So I want to capture that picture because that's me. Okay, that's like me in the village in Cameroon where I was born, right? You play football, you play soccer barefooted. Actually, you will not even have soccer. That's a real soccer ball. Sometimes you just take leaves and you wrap them together into your ball and you kick it around. And that's how you don't have access to all the nice stuff that you have here. I would walk 5 kilometers barefooted to primary school and back, right? And so why do I say that? My parents really valued education. They gave everything to make me be able to do that. But I say that because standing here and talking to you is for me a miracle. Okay? How far I've come from that particular position. From somebody where even getting out of my village looks like the world beyond. Looks like going to Mars, right? That's how it looked to me. But to me, to be able to stand here and then talk to you and actually be working with you, partnering with you to eliminate disparities, that for me is a miracle. Okay, and so that's part of the reason that drives the whole idea of making sure that there's an African saying that if you are on top of the pear tree, you want to make sure that your brothers who are at the bottom of the tree also eat the fruit. Okay, for me, if you've been able to have the privilege of climbing up the tree and reaching at the fruit, these opportunities that we have in the United States, you want to make sure that you don't forget the people who are at the bottom of the tree. And some of those people, for us, some of you really do great work, and I really admire Americans who come to developing countries and try to help, because they really inspire us because they leave their countries and come and try to help. And so I get inspired to do something too. I mean, if they can come all this way to do something, and we diaspora sit here and we can't do anything, then that's, so you inspire us. But the people who die of cancer, they are my brothers and sisters. And so that's very, very personal. I put there to the right side, the Black Panther movie, Wakanda. So Africa, the Africa where people want to become, right? Wakanda, if you watch the Black Panther movie. Actually, the parents of Lupita are here, the youngest. Let's work, let's recognize them. Their daughter, Lupita, is actually one of the biggest diaspora, right? Ambassadors, because she's been so successful. She won the Oscar Award, as you guys know. All right, so why did I put this slide? So Einstein basically talked about imagination. And I think that part of the reason why I can even stand here and talk to you is because I have an imagination about a situation where I have hope that things can get better. And it's really everything and so important. This picture you see here was published in the New York Times. And this New York Times picture really broke my heart. Talking about how Brenda, I think she's from the East African, Uganda, or one of those countries. She's hiding her face. She's diagnosed with cancer. She doesn't only have to deal with the mental issue of the cancer. She has to deal with the fact that they think that she's bewitched. She's a witch, right? So that's a cultural, that's something that you have to deal with. And most cancer patients, they don't only die of cancer, they die a painful and distressful death, and that kind of stigma. We really have to do something. So that's really, really important to see where this is going. So this is also talking about Felicia Noah, who is really one of our mentors. Now she's at the University of Miami. She published this article talking about the pain divide, the injustice, that you don't only have to die of cancer or this disease, but you have to die of pain, just because you don't have access to pain medication. That's something that, we need to also change. A couple more slides. So I just want to mention about why part of the reason we're here, cancer, right? For those of you who know the Avengers movie, Thanos is the villain, right? So it's like the monster. You may think that cancer is so far away. Somebody mentioned that today, but it's not far away. The statistics show that the person to your right and the person to your left, one of you is going to develop cancer in your life. You have the risk to develop cancer in your life. So it's not that far from you, right? So that's part of the reason why we're doing this. And now we actually know that there are 4 main ways that you can treat cancer. There's surgery, there is chemotherapy, there is the radiation. I'm in radiation oncology, so this is actually one of my favorites, of course. And I brand that person, I used to brand him Iron Man. Then Iron Man died in the last Avenger movies. Did you watch it? Yeah. So he died. So now we've shifted it to Captain Marvel. That's why there are a lot of women here now. Women power, right? Captain Marvel. Yeah. So that's radiation therapy. And then we have immunotherapy, which is Black Panther, the newest guy in town, right? So, but why do I show this? I really show that the Avengers movie show that, you know, by bringing together all these superheroes, working together, collaborating, they can be able to beat, you know, the monster cancer with Thanos. And we saw that the movie really captured that very well. So, you know, in 2015, we won the award to develop tiny drones to target cancer here. And that was really combining, you know, like combining Black Panther and Captain Marvel, not Iron Man. And so immunotherapy and radiation together. And my colleague, Jonathan Schoenfeld, gave a very brilliant talk this morning talking about how you can combine that. But then he ended by saying, what about the rest of the world? You know, this is really expensive treatment. You know, not many people have access to it. How can we get more people to have access to it? And he showed this slide. I'm going to show it quickly. So if you look here to the left, that's cancer. The drone technology works to your left. So that's a primary cancer that you have, and you want to treat that, right? And then on the other side to the right, that's the cancer that has spread to other parts of your body. 90% of cancer patients, over 90%, die because the cancer has spread. Right? So if you're only treating the local cancer and you don't treat the cancer that has spread, that's why patients die, right? And so when you take something like chemo, you're basically trying to target all the cancer everywhere, but because it's not very precise, it's like, you know, poison you're giving to the cancer. It also poisons your healthy cells, you lose your hair and all of that stuff, right? So in this case, the real good way would be to train your immune system. That's why it won the Nobel Prize, right? But it turns out that to make more, we found out that if you can shoot one radiation dose, to the cancer literally starts to bleed, and it releases these signatures that your immune system can take up and become primed to eliminate the cancer in other parts of your body. So your immune system is like your SWAT team, right? Like your soldiers, your defense. If you can show them how cancer looks like, because it always camouflages, then it can eliminate the cancer. It doesn't matter where it is. And that would be a safe way to do it, you know, without you having to have all those side effects. And so we've decided to test that in animals first. So basically we developed a very simple model. We have the cancer on one side. We're just going to treat that one and watch the cancer in the other parts of the body that we didn't treat. If it really works, both cancers should shrink. They should disappear, right? And this is not really just my work. I really have to, you know, say that this is a collaborative work. Very good people in my lab who have done excellent work. They've won a number of awards, just trying to find out what the best parameters for this are. But one main thing that they found was that, you know, if you look on these pictures, this is the animal I just showed you. The cancer on the right, cancer on the left, right? So, and what happens is I just treat the cancer on the left. Combination of one radiation therapy dose with the tiny drones that releases the immunoadjuvants. And what you see is the only group that eliminates is on the far right. So this is a great work by Michelle. It's Michelle here. She did that work. That's really fantastic work that has really generated evidence to show that this can actually work. It's moving from a hypothesis now to something that patients can actually access. And we're planning the clinical trial. Paul gave a talk, my colleague Paul Ngwa, I don't know if he's still here. So he gave a talk about that this afternoon, showing how we are working on the clinical trial for prostate cancer. So this is really, but it got me thinking, right? So, this one slide shows that you can actually cure the animal completely, and then when they give it cancer again, it doesn't develop, right? So it means that the immune system has been trained, it's primed, it's ready, right? So you don't have the recurrence issue. That's what you have to do. So it develops memory. And so this is really encouraging. So now we started thinking about, Brenda, who is living in the village in Uganda or Kenya, who has cancer that has spread. Can we get this to her, right? So the question comes up, if you are diagnosed with cancer today, which expert would you see? A medical specialist or a money manager? Okay, this is a question that was actually on a news article, and I really thought that was powerful. It turns out that the answer to that is that actually the biggest specialist you want to see first is your money manager here. You have to think about how are you going to afford the treatment. If you don't have insurance, health insurance, that's a big problem, right? You get bankrupt. The treatment. So do you know how much it costs? Averagely, it's about $150,000, according to this article, to get treatment for cancer, right? So how many people can afford that? I mean, in a developing country, not even think about developing countries, right? My colleagues like Dennis, who is sitting over there dealing with cancer in Bingo in Cameroon, would tell you that they really have to do something major, otherwise nobody will get this treatment. Nobody's going to get this treatment. So we started thinking about this. With the evidence that we're generating from the research and the science, we proposed the fact that we can actually, make this more affordable. So one of my associates, colleagues, Credit, is he here? Yeah, so he did a very excellent work that's actually in submission. Where you can look at this and say, science has already been done that shows that if you're a cancer patient, normally like prostate cancer, you take 39 doses of radiation fractions. You take fractions 39. But evidence now shows that if you do just 20 of them instead of 39, you can get no inferior outcomes. You get equal outcomes, right? So why would the patient go through the conventional route of doing 39 fractions instead of just doing 20? And so the question is, if you can reduce those fractions by half, it means what? It means that two patients can actually have access to the treatment in the same time that you would treat one, right? And that's a big issue in most of the developing countries. Like Twalib would say, where's Twalib? He would tell you, patients travel hundreds of kilometers to a radiotherapy center in Dar es Salaam, but they have to wait weeks to get access to treatment because the queue is so long. If you can cut down that by half, that's already a big access advantage that you get there. So Credit did a nice calculation about this and showed that this can really significantly increase access, but also the cost, almost halving the cost of the treatment. So we decided to take this one step further and said, well, that's if you give 20 times the 20 doses of radiation fractions. But what if you just give one? Instead of giving the 20, you're just giving one dose of radiation. That means that you're going to have 39 patients instead of one over that time, right? And that's what the scientific evidence with these animal studies are showing, right? Take note that, showing that in animals doesn't necessarily translate to humans, but it tells us that there's a big probability that this can actually happen, right? And then you calculate the cost of that. So if you calculate the cost of that, we actually see that that will be a major cost savings. It brings it down to less than $300 to treat a patient who has cancer that has spread to other parts of the body. Yeah. That would transform healthcare access. It will, And so this is something that, we're very excited about, and most of what drives some of these collaborations we're doing. So earlier on, we actually talked to a number of centers. Professor Kerr, David Kerr, who is not with us today, he's the professor at Oxford. He's actually in China doing a clinical trial network. Oh, is it India or China? He's partnering. So the initiative we talked about earlier today is called AFROX-H. So it's basically Africa, Oxford, Harvard Clinical Trials Network. And we want to grow this to other countries. The idea that we can do this multi-center clinical trial, not only doing it here in Boston at Harvard, but have it done in Europe. People also need that in Europe, okay? And then look at other countries in Africa. But today we actually have people from Bangladesh here, from Pakistan, so we're in South America. So we can do a multi-center clinical trial that allows patients there to also have access to this, right? And obviously you want to do that for all these populations because that's actually the disparity, is that most patients in these countries don't have access to any clinical trial. And so we're very excited about doing this. So we talked about the possibility of starting this clinical trial and also extending that to Africa. And I'm very excited about that. So we think, in conclusion, that the possibility of increasing access to cancer care for patients, curative treatment, as you saw, if you can do what we did with the animal, cure that animal with 1 dose of radiation therapy fraction and less than $300 in treatment, if we can take that across the world, that possibility exists right now, okay? And, I'm here to say, we can all collaborate to make this happen and have more patients have access to treatment. Thank you very much.